So 6 and 6.
Yeah. Okay. What is shared decision making? It's a collaborative process in which clinicians and patients must work together to make decisions. It integrates clinical evidence because the physician is there to present the clinical evidence and use it in treatment, and compare it with, use it in accordance with patients' values, preferences, and circumstances. I mean, we are all different. We have different ways of life, so that should have a role in making decisions on treatment and care. A video about shared decision making.
What can you do in your everyday practice to ensure people are equal partners, making decisions about their treatment and care as much as they want to be? Shared decision-making describes an approach to healthcare conversations that recognises there are two experts in the room and supports people to make informed choices about their own care and treatment. Evidence suggests that professionals interrupt people within 20 seconds of speaking, and only 5% of their time is spent answering questions. So, how do we prepare for these conversations? Firstly, understanding of the situation and what really matters to the person, and active listening is key to this. Secondly, information sharing, including the benefits, risks, alternatives, or doing nothing in relation to all treatment options available. RAM for short. Benefits of this treatment or intervention, risks, balancing any downsides there may be. Alternatives, weighing up other options and preferences. Nothing, but sometimes taking no action is the best option. And finally, involved and empowered. Decisions should be made by the person, together with the professional, working in equal partnership. To find out more, visit realisticmedicine.scot.
It's very important what has been said, that there are two experts in the room. One is the physician and the other one is the patient, expert in their own disease. I found this from NHS about shared decision making. Prepare people and patients. Here. So patients and should be prepared for every meeting by maybe making notes. So we have also a task to prepare always before the meeting so that we have enough time to discuss with our physician. Supportive systems, the systems should support this process, and maybe also measurement tools available. This is very important. We need to know, we need to measure how shared decision making is used. Provide trained teams. I think also the physicians should be trained in order to use this shared decision making, because it's not that now you have the patient, have the doctor here who is, he used to be God, and then the patient there, and he used to make decisions for you. Nowadays, this is not the case. We should make decisions collaboratively. And redesign pathways to embed social decision making and minimize health inequalities. That is very important because there are health inequalities. For some people, access is difficult. There are different levels of education and health literacy, so this should be minimized. So this shared decision making should be achieved. Why shared decision making matters? Because it leads to better adherence. If you decide with your doctor what type of treatment is suitable for you, then you are more likely to be adhered to your treatment. I think we all find this as personal experience. It helps the patients make informed and value-based decisions because, as we said, the physician should provide the evidence on which treatment is based and decided, and can reduce unnecessary tests or procedures. The key components of shared decision making is the information explained. Though the doctor explains to the patient the options they have, the benefits from each option, according, as we said, to lifestyle and preferences. There should be a discussion in the context of these particular patients' lives, and decision should be reached by a consensus in the best path forward. What are the tools that can help us and techniques? It's decision aids, pamphlets, video, apps, which can be used by the patient, open-ended questions to elicit values, and option grids to compare treatments so that the patient with the doctor, they can make the best decision if they can compare the different options they have, if there are. There are some challenges in shared decision making. Sometimes there is no time in clinical settings. The physician has limited time, so they want to finish as quickly as possible. And there's also variability in patient desire. Some patients want to be involved. Some patients may not be so keen to be involved in this process. Some information can be very complex, so the doctor has to explain. Sometimes it's very difficult for the patient to understand all this information that is given to them. Cultural and language barriers always, and as we said before, low health literacy, which is very important. There are different levels of health literacy between the patients, so there are limitations as to what some people understand about their health and treatment options. What can we have strategies to improve shared decision making? We can train clinicians in communication skills. This is true, actually. Some clinicians are more skilled in communication and some are less skilled. So here we need training for both sides, and many organizations have self-management approaches and trainings which can help this type of communication. They need to, the patient activation and education should be encouraged. I mean, sometimes physicians say that you shouldn't go to Dr. Google, but the truth is that there is some information there which is reliable. You have to know your sources and find the most reliable information in there. Integrate social decision-making tools into electronic health records, and foster a culture of respect and transparency. I think These are very important, both respect and transparency. Do you have any questions? So to conclude, as we said, shared decision making, it's a collaborative process. It is essential for delivering ethical, personalized, and effective care. And this I found from NHS, no decision about me without me. And that implies, of course, empowering the patients, and that's why I talked about these self-management tools that organizations have. They said, because we have this in Cyprus and we implement a self-management program, and I think it does help towards that a lot, towards empowering patient to say, yes, I am the patient, but I am an expert in my disease. The clinician is expert in science, and we need to work together to achieve the best patient outcomes. That was my presentation, and now I want you to split into two groups, 6 over there and 6 over here, and find somebody to write for you. And I want you to think of some guidelines. One group will think of some guidelines to the patient on how to achieve shared decision making, what can be done, how the patient should be up to a good communication so that there will be a collaborative process and shared decision making. And the other group to talk about physicians, how to, some guidelines which maybe we give to Sjögren's, and maybe they can serve as guidelines which can be disseminated to the patients. So how the physician can prepare for this decision making, what can be done from his part so that this process would work. So please find a person for you to write, and then discuss this, and then we come back and we can feedback what you have thought. Okay?
Did we do the physician?
Okay.
I'm a physician.
Yeah.
So
Six of you. Yeah.
We will do the physician here.
And you do the patient.
Who is who?
We are physicians and they are the patients.
Go to the whiteboard 6.
Okay.
Yeah.
Have the other, because if I say what I want you to know,
Yes.
Let's go closer to the whiteboard.
Yeah.
Why not?
Yes.
I want to go.
Okay.
I'm fine.
Maybe we should take our thing to the home.
Yes, guidelines.
I think it's maybe.
I would say, sort of tips and tricks.
Yes, tips.
More
Yeah.
formal.
Yes, less formal. Yeah.
Yeah.
Sit down.
Be careful, Veronica. Behind you.
There is a big table behind you.
And he's the spell checker. Oh,
It's very strong, it's no problem.
so.
That's better.
I was. Now I'm getting
That's better. More space there.
We are patients.
Maybe you're right.
Oh, all right. Most easy for you. Yes, everybody's patient. Yeah.
Maybe we should start with the doctor.
Take time to know your patient before you want to.
Before.
So prepare.
Before.
We should say take time. You give the patient what the patient.
Well, that's not sometimes.
Yes.
Yeah, sometimes your hospital or your
insurance, they mandate how long you have, but sometimes it's okay to take time. But if you, before clinic starts, I usually would try to take time to look who's coming in today. And
See who's on your list.
see who's on my list, look, so I at least kind of know what's going on, so I don't spend half the clinic trying to remember who they are.
And how many times do you need for that?
How much time do you need for that?
Yeah.
From 2 minutes to half an hour, and you're little minimal 5 per person. Sometimes it's very easy, sometimes it's long one for
There's a new patient, you have to take a lot of time.
But sometimes it's easier
Well,
than
sometimes
to put the time into the
It's a
patient.
patient you've done for 20 years,
Thank
you
you.
don't even have to.
You don't know if you know the patient's went to
You need, no, you don't need to, but if it's the second
We
time
have
you've seen a
20
patient.
minutes, and then we have 5 minutes to discuss the wrap up, and we have to finish at 10:02. Does not allow him to breathe.
Yes.
Yeah.
That's not absolutely true that you
Yeah.
need to check,
Yeah.
because between 2 appointments, things could have happened.
Yeah.
Sometimes the surgery, sometimes the death in the family, sometimes blah, 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 blah. So it's very important to check, to give the freedom to the patient that are aware of what happened to him or her.
Yes,
So like,
write
hey,
down
it actually helps a lot with
every
rapport, you come in
question
and
has,
you
so
know
he
your
will
patient.
not be stressed.
But you only-
How's your child?
Appointment,
Yeah. Numbers not
But the thing you mentioned is you can only ask.
It's easier for you.
Well, I think
Things
the
change.
electronic, like, yeah, it's better, you can see that they.
Yeah, but
Appointments
dying
on a
from
surgery
Yeah.
or an ER. Save
Okay,
time.
yeah, but dying from a family.
No, maybe you would, yeah.
No, so you have to ask.
So it'd be mostly stuff you can find in the electronics.
When they reach me out,
Yes.
I have some notes about very important events, and I keep them tracked in the individual file, even when it's personal, because that can influence the appointment journey.
But also it saves time because you don't have to react.
Yeah.
more than just help the emotional.
So know your patient before from your record? Yes.
Right, because then you can spend more time
Yeah.
talking about their
Exactly.
needs, their questions and their issues.
Then it helps to know the person in a holistic manner, doesn't it? I mean, not just the patient
No.
there.
Exactly.
References, culture.
One time
The patient knows that their
Yes, I
doctor
agree.
knows.
Yes.
People like low hanging fruit and then
You're always good.
pass.
Yes.
You think
Come
all
and
those
listen and
is
think.
No, they don't.
Yeah, it's more information, I think.
And that surely must be a challenge for dealing with patients.
Yeah, our
potentially systemic disease where they're affecting different things.
So
Yeah, I mean,
since
you
the
can,
start.
it's hard to
And
be.
we're going to use that
I know this
consideration
idea.
for
Like a track this.
Yeah,
For
definitely.
this one.
You mentioned, listen to the patient,
Please come, you said that to me.
because here we were before the consultation of the
So,
I
beginning.
love that
I'm
idea.
not going to, exactly.
Okay, I
For
respect
everyone
that.
that there is always a
Okay,
time
that's
I managed to keep for, okay, tell me what happened to you before the consultation in the last month.
Yeah, they have information. Yeah, exactly.
Yeah, about the disease and about anything else, like, yeah, you are under,
What's bothering you?
yeah,
What's bothering you?
yeah, but also like you are under immune drugs, if you have any infection, for example, that's very important.
And work and children and well.
Everything.
That's part of what I was saying.
And when it's too long, I say sometimes,
Yes, and support.
please focus. Sometimes it's,
Yeah,
But 10 minutes is.
Open-ended is hard when you have to have a focus.
Yes, that's a chance much easier to connect their
it depends on the
Education.
Yeah.
That's all.
Okay, you have more time than the 10 minutes.
45 minutes for about
Yes.
45 minutes
Let's all move to it.
per patient.
This is
No,
Geneva.
fine.
Yeah.
Where is that?
Geneva.
Excellent.
First consultation 1 hour and follow-up 45
Excellent.
minutes.
10 minutes is enough.
I was at Georgetown, we had 45 minutes for noon, but we had 15.
The thing is,
15 is enough.
15. We were an academic center, so. Yes, we have more than
Well,
don't know how
before
much-
in France,
do
I
you
just
know
have
how
half an
much
hour
it's
for
gonna
first and for the. But the thing is, in Switzerland, you make it time. So there's no issue.
No,
You can
it's
last 2 hours.
Yeah, but
It won't change everything.
Yes.
Versus
Then one of the questions could be, how do you feel? I mean,
Yeah, that's
like
what
psychologically,
Yeah.
How are you doing?
how are you doing?
Seminars or meetings, the people are not so much interested.
Do you, when you say
Even though they
targeted,
were
do you
trying
say,
to,
tell me about what's
the
troubling?
people
How
are
The-
is
not
the-
interested.
Yes.
Sometimes the question, how are you doing, is not the optimal one for
Yeah,
everyone.
even
So
though
it's
we
good to
don't-
refocus, saying, okay,
Not
what is the
interested
thing
in
that
job.
you struggle with the most?
Maybe then the
Tell me,
people
because I cannot solve
need to
everything
spend
in one
some
Yes,
time.
So that's the other thing is setting expectations for the
about
visit.
their disease.
And so if you come in with open-ended
To
questions,
follow
if you
the
start going off a
seminars,
laundry list and they whip out, two
Participate
pages,
in
set the expectation, it's
meetings,
like, we'll get to
to
as
share
many of
their
these as we
thoughts
can.
with other people so they
And
can
they'll let me know what the most important is.
No, I'm actually I'm French, but I was in US 2 years in Geneva, Switzerland.
Ownership.
Yes, it's a partnership
Sorry?
approach.
Did you know Maria
The
Navarro?
ownership of Michael.
She's
Yes,
rheumatology at
exactly.
No, sorry, CSF.
Only as a
I didn't
Yes,
know
yes.
there,
And the
so
pharmaceutical
mostly
part of the
basically
business?
science.
So I need to dedicate myself, so to learn how to deal with my symptoms.
What's your health
I
question?
learn
Is
from
it
other
who's,
patients too.
You know that
Yeah.
health question?
So
So
not
the-
sure you're right,
What's-
you know, confidence.
What's bothering
Uh,
most at this moment? What's your question for
So
me?
these
Yeah,
are action.
that's
So
very
in the
important.
Netherlands we call it a health question, but what's your health
Based on
question at the
that.
moment?
I think it's here.
They'll drive.
Yeah, what's troubling you the most?
Yeah, and how can I help you?
And
Yeah.
how can I
How
help
can
you?
I
It's
help
more, what's the question?
Eh,
And how is that?
Yeah, but sometimes this question will bring the answer you don't want to hear. For example,
This and this.
no, or my husband died 3 months and I don't sleep anymore. And unfortunately, I can't do anything with that. So, okay, a lot of empathy, but we need
You
to.
can do something. You ask, have you gone to grief counseling? Oh, if not, I'm gonna have my
So
therapist.
signpost.
Yeah, but you cannot solve the issue.
No, no.
You need to
But you can
listen
But
to.
you hear it.
Yeah, sure, it's very important.
Yeah.
Because also it can affect the disease
That's what you
evolution.
can ask, is has your disease flared?
Yeah, exactly.
Yeah, how's it affected by that time? All the symptoms, how would life events affect the real world you're suffering from? So, I mean, you're the first actor of your own disease, and you know how to cope with the disease. You know how to feel better.
That's fine. I
When
think
you
it's
have
enough.
a day.
This is a very important point because we need to manage a plan. This is the thing that makes the difference between a successful treatment and unsuccessful treatment. We will select something for doing something. We
Yes,
start from point zero.
You
We
made a
expect to
very
have
bad,
this
you
result
make a
at
list before the
1, 3,
appointment,
1, 6.
prepare for the
So, okay,
appointment, yeah.
I
go
can't
there
see you
without
every
the
day
stress if you
up
forget
to 6
something,
months. So
but
you'll have
and
to
write
keep in
them
mind
down,
that
your
the aim of
questions, your
this treatment is
so
that
when you go there,
at 6 months,
to be
3 months,
able
whatever,
to
I expect from you
ask
to say
the information
I'm
you want,
worse,
get the
better,
information you
or
want.
steady
Help
state
yourself
about
get
this,
rid of
this,
the
this
situation.
symptoms.
Yes, but
It's
also
very
asking
important to
questions
explain
when
to
you
the
have a
patient what we expect
conversation.
from those
And
treatments.
there's
Because if
something
we just
that
say,
you
okay,
cannot
I hope you
understand.
feel better.
Yeah.
Sometimes people are
What it means to feel
Yeah,
better
right.
about what.
Yeah, so clarifications, I would
Cure is
say,
clear,
about the
and
directions.
if we have
of
biomarkers
the
in patients, it's even better. It's very
Not to be
important to
shamed
explain
to
that
ask
to the patient.
questions.
After
Yeah.
lunch, Joyce will
It's
show
an
you.
exchange, right?
Yeah.
Whatever
It's like
context.
brainstorming.
Netherlands for
We
this.
give you take and it's brainstorming for.
I know they are very
You
proactive.
know it already, I think.
Yeah.
Just a question. You see any patient by phone, if you haven't got time, let's
Yeah.
say the patient comes, you have to also by phone if it's a patient that it's a long term, that you know it was a long term. Can you phone you, making a call by phone, and he will tell you what, yeah?
Or sometimes, for example, I can give you a practical example better. Sometimes for arthralgia, it's difficult to say they are mechanical or inflammatory.
Right.
So sometimes I do
Right,
test with steroids at very low dose for 3 weeks, for example, just we will test if you will be eligible for and I will call them after 3 weeks of treatment, 3 weeks of washout. So, okay, explain to me now how it was under steroids and how it is now. And we can't
Saves them a trip and saves you an appointment.
Yeah. And like this, I can consult much more patients in terms of options.
Yes. Keep in mind. Can I add something that isn't about preparing for specific consultation? It's a bit more around early training. So at our I work at university in clinical research and dentistry, but our medical students, our first year medical students, there is a scheme that the team work with the students, teaching team, match them up with patient charities, and they have a group students have a one conversation with a patient. I did it 3 months ago when they seek to understand your disease and how it affects you.
That's very important. And if you feel you're not well mentally, it's good to ask if you can refer you to some specialist or something.
That they really,
Because
really
usually
need it,
you
even if
don't
it's
talk
not
about mental
something that they
issues.
see themselves
Do you?
Right.
developing in their
Yeah.
career. The fact that they spoke to somebody with your disease just helped them understand it, and then our charity is invited to them. I'll show them to pages, invited to them to come to our conference, and then write a short report on how they found by being
Any
a
way
patient.
to improve that side matter.
Start
No, and actually that can help steer some medical students into,
well,
yeah, they're like, you know what, I'm just gonna get that out.
It's
If
a
they have
part
like,
of the disease.
or I wanna have chronic long-term relationships with patients, and they'll go to something like dermatology.
none of them did. So,
None of them did.
so they were
Yes.
you're very young, you're very young. Yeah, there is that.
Yeah, so early training of physicians to improve
Then you should ask for help if you think you need it.
communication with
In
patients.
any level. Yeah, yeah.
We call it
ask
just
for
bedside.
help, definitely.
So,
First, that we can show up as a human being. Because the disease burden is not about symptoms, it's about how this affects your sleep, how your daily functionalities, your work, your life as a wife, a human being beyond.
Mention your difficulties in your daily life because we have a daily life that we have to cope with.
like
You have children, you have work.
Yeah, because our existing diseases and then doctors.
So I just get osteoarthritis foundation, palpitations, bring an advocate,
I
bring
couldn't
a
sleep
list.
the whole night.
Yeah.
Exactly.
And then actually, you need to also prepare that up.
Bring your
Yeah.
The doctor can see, oh,
prescriptions,
Yeah.
the worst thing for us.
I
I don't know what, I don't know why I'm here,
Bring it.
and I don't know what
They're not in your system.
drugs I
You're
take.
invited to bring it, that's important.
It's on the list, but sometimes I say my wife knows what I take. Okay, but she's not here.
I want something for something.
Yeah. You know, blue pill for the tension.
But a lot of patients
And you
rely
talk also
on the
about
doctor.
training for
This
patients?
is,
Yeah.
I think so.
I think it's
Joint
obvious,
patients
but.
are-
So that's what
That's,
Yeah.
yeah, my brother doesn't know what medicine he takes, and he doesn't know
Patients
wife,
organization
he
for
children.
girl
So
or
we
something.
make a photo from a list.
Right, but he
and
has a
we-
smartphone, I think, right?
Yeah, but he never uses it, but it's,
Yeah.
so
Take a
it's,
picture.
so I know what you
And you
mean,
know,
but
it's
it's
a
difficult.
white pill or pink pill.
It's to be honest, it's not for all patients. What she
They
said
have
is,
territories
great,
and
but
they have
let's say probably 30%
Ah,
of patients
and this is
don't
very
want to do
good.
that. They said to me,
I
okay,
received
you have the
many
knowledge, I don't want
patients
to
and I
select
asked them
anything,
to say
but I
they
trust you. You do, you explain to me, and I explain.
We
I
can
don't want to
translate
take the decision, but they said,
exactly.
you have the knowledge, take the decision. I don't want to take all of that. And
Because I
it's
like
not
this
clear.
idea a lot.
Even in chronic disease.
But
Oh, she's afternoon.
higher percentage of those
Okay,
patients
and
are
we
the
have
ones that are more likely to
even
be because they don't have a relationship. Just mutual
mental
decision
health.
making.
I would say it's
So,
another group,
when you
and the non-compliant. But this group is very compliant. They say
before you go there,
they are very
you
trustful.
I think it's cultural.
42 questions.
Potentially,
in
yeah, sure.
about
And not
this
less in US, but in
uh,
Europe,
Yeah.
some of the patients are like this.
So I trained in LA, and
more
I
about
mostly
the
Latino
quality
population,
of
very
life.
trustful.
Also,
They-
even
Had a
better.
practice in
So,
Washington
yeah.
DC.
Even better.
African
Yes,
American
so we're
population.
very
They didn't trust
No.
any of it.
Physicians,
Not
provide
like
patients
Yes.
with psychologists.
There's
Individuals.
individual, but
Yes.
cultural, and so
Profound
just, and their
information.
shared experience with the medical field.
Outside of cultural, I would say social.
Physical
Because your level of education
You may
is
bring
very
it
important in
to
that.
first visit and then
the job you
Yes,
do,
and
the-
see whether there is
many
exactly.
things.
But I don't know.
Yeah, this is very
But I think clinicians need to strive, especially in rheumatology, as hard as possible to
It's okay,
establish trust
so you should be
and have a positive relationship with the
doing
patient.
it regularly, once a month.
Go out of their ways, just, this take time to know.
that again is based on the patient.
Sometimes I would like to introduce several treatments after one consultation, but I know if I do that,
Everything that
Too
you
much.
they will not be compliant. So I say, okay, let's focus on one thing.
for the
We
consultation.
will do this way, just say we will meet again in 3 months. For the second step, we just focus on one thing at a time, and it works well. If you say, okay, I will introduce 7 treatments,
But you never know what ended up working. Or if it's a side effect. You
yeah,
never know.
yeah. That was a caricatural example, but
Yeah.
one at a time.
It's good.
Sometimes.
But we are now focusing on this.
Also simple
That is
things
good.
like being on time for
Yes.
your
Yeah.
appointments.
Yes.
Yes, because the doctor
Yeah.
is busy and other patients are waiting there to see
Yeah.
them.
But the
So
doctor is sometimes called too late.
yes, that's
Yeah.
true.
But we are on time.
He on that one, but he also is human, as to say, the on time.
On the other side, I
For
always
sure,
think,
there will
okay,
be overlapping.
the doctor runs late, he has
It's all about
uh,
awareness.
time for the patient. And if
There might have been someone in
The
need.
patient.
Yes, and if I
Five minutes.
that's
Yes.
I
I was seeing a neurologist and my appointment was getting really late. She was in there, she was another patient.
The air
Had to
conditioning
wait
is
half an hour, 45 minutes.
No, I
And
don't.
she got shocked in the door for a month. How long is this going to take?
It's very nightmare to have them
I
to stop
take
this.
as much time as
It's
is
not
needed.
the air conditioning.
So I really felt bad
Everywhere.
because she was right.
So you like Geneva? I thought it was Wichita.
Yeah, I like Geneva.
But it's
I
nice.
fly to Geneva twice a week.
Oh,
You-
so I do it well. It's an efficient one.
Yes,
It,
that's
it
the-
works well, yeah, I like it.
You can
It's
use
a
an
flight
answer
EasyJet to
to
Philly.
the
It's
assistant.
my wife and kids.
Yeah, PA of the doctor.
Monday and Friday, I fly back to Copenhagen.
Yeah. So maybe talk to
It's okay.
the.
It's a lot.
You have a nice mass
Yes.
account.
Yes.
If the doctor
Oh,
doesn't
okay.
have time.
Yeah, it's nice. Expensive but nice.
I'm surprised how
Yeah.
inexpensive Wichita is.
Oh,
We can submit some.
It's not bad.
So we
I
can
have an
write that
apartment
the
that's 60
patient
square
needs to
meters.
be on
It's
time
right on the
at his
lake.
appointment.
Old historic quarter. It's including utilities, 1,200 francs.
We can discuss with the doctor. We can discuss with
Euros.
the doctor. Yeah.
yeah, it's
That's not that much. Because I know Spanish restaurant is very expensive.
Yeah,
But
yeah.
it sounds-
Geneva
it
is
sounds-
6,000 euros a month for.
yeah. Yeah. For house, yeah.
1,400 for the whole
That is
place.
something else.
Yeah.
Thank you.
But what is expensive in Ireland to general is the garden. You have
At least I hope that I can
Toulouse
read it.
outside,
Oh, yeah.
outside, at home, it's very expensive.
I worry my daughter to the university.
Ireland, oh, that's very nice. I was studying in Ireland also.
Sorry?
Susan, do you want us to bring that here?
Yes, so then we can feedback.
Rooms can be,
So let's feedback and discuss whatever is needed to be discussed. Okay.
Okay, we are in the field of patients, and we have prepared several advices, and as we name them, tips and tricks for patients. First, which was mentioned also previously, the patient shall prepare and collect a list of questions that they ask themselves or that they would like to know more before the visit to the physician. Also, it's a good practice to collect information as we know in Netherlands, they have something like a symptoms card or questionnaire, which the patient has in hand and which he can fill in regularly, so that they can track their condition. Also, good advice is joining patient organization, patient support groups, join trainings. Nowadays, it is even easier to simply join a Facebook group with people in similar condition where they share their own experiences, their advices in a simple patient language, and where patients can see that they are not alone. There are some other people who went through this challenge. And another advice is simply master your disease, master your condition. Everyone should know that it's your own responsibility to take care of yourself, to take care of your health, and know that you are the expert about yourself. So go to the physician with the self-confidence, with confidence that you are the expert of how you feel, and don't be afraid to ask or share or ask for clarifications during the examination and consultation. Sometimes you or we as a patient might not understand what the physician is saying. Don't be afraid to ask again, to repeat, ask for alternatives, ask for the risks, ask for what would happen if you do nothing, and ask for benefits of this condition. Also, for your confidence, ask the doctor if they would prescribe this therapy to their mother or to their children, their own children. If you have some concerns regarding safety or anything else. Don't forget and don't be shy to mention your daily life, how you are feeling, your mental health, which, as we heard earlier, could be a part of the overall symptoms of the diagnosis. And last but not least, be on time for the appointment and respect the doctors. Also respect their time and respect the fact that sometimes they might not be on time because they need to pay more attention or spend more time with somebody else who is in need at that moment.
Thank you.
That's it.
Thank you. Any points from the people from the other groups? Anything to add? Okay.
Okay, thank you.
Thank you.
All right, from the doctor's perspective, what can we do to improve this shared decision making? And so time has been coming up a lot because depending on where we practice, we get more or less time. But one of the things we can do as clinicians to improve the time spent with the patient is to prepare for a visit better. And that includes trying to know your patient as well as you can. Even the day of the visit in the morning, you're looking at the list of who's coming. Just spend a few minutes per patient, going through, making sure you're familiar with your disease, adding some personal information if you can, because that establishes rapport with your patient, like understanding if they're going through financial troubles or family health issues and things like that. So when you come in, patient has a rapport with their clinician, and then you can go through that and then get into the disease process conversation. Keep track of key events, holistic approach, etc. Listen to your patients, ask open-ended questions, then focusing down when it becomes appropriate. Asking the questions, how are you doing, right? And so these are the things that patients want to hear about, and this will put a dialogue between the patient and the clinician. Asking the question, what's troubling you the most? And so this is kind of setting a hierarchy and an understanding that we're not going to get through everything, but I want to understand what's bothering you the most, and if you put that out there, then the patient will feel at least they're starting to get heard. Setting realistic expectations, both with the timing of the visit, how much time you have perhaps, but also when you're talking about medications, talking about treatment expectations, talking about risks and benefit ratios and things like that. Being frank and understand the patient is knowledgeable and they know what's going on, and so don't try to dumb it down. Just when you think it's going to help them understand it better. Understand that your patient's going to, I mean, speak in lay terms, but set the expectations of what you can expect from a certain treatment. So we had a really good observation from one of our presenters who was pioneering looking at how to improve empathy and bedside skills early on for clinicians. And so I don't know if you wanted to speak real quickly to the medical school experience you have.
So I'm a volunteer for Sjogren's UK, and I work in the university, and the medical students, first year medical students are paired up with rare disease charities and representatives from rare disease charities, and we have a conversation, maybe 2 or 3 medical students, somebody who has a disease. So I've spoken to some medical students about my experience of diagnosis and of living with the disease. And these are very, on the whole, very young people, very early in their career, and they've said it's given them a really good insight. So not necessarily that they'll eventually go into rheumatology or immunology, but that it helps them understand what's required of them in consultations and their approach to patients. And we've moved on from that from 2 people, 2 of the students that are at our annual conference in the UK today. So they're going to write an article for our newsletter about their experiences of hearing patient experience of the disease. So it's formed a partnership at quite an early age, or an early stage of career.
Empathy is very important, yeah. And they need to come in contact with the real patient, even for students, because we have this program here in Cyprus, the patient expert. So we visit students, medical students at the universities, and then we talk to them and we show them what it's like to live with rheumatic disease, especially also with deformations and all that sort of thing. And they enjoyed it very much. And we also train the nurses, because they have a nurse training program, and they invite us, they give us a whole day to show, to talk to them about self-management and present our programs. And it's very important, because also, I don't know if you talked about the nurse, but the nurse can be a very important stakeholder in this relationship.
100%. I've had patients leave my clinic because they didn't like my nurses.
Yeah, you see?
Yeah. And I went to the British Society of Rheumatology conference with the charity a few months ago, and we did have doctors coming to the stand, but we had lots and lots of nurses saying we need some resources. What can I say to patients when they're newly diagnosed and they're feeling overwhelmed? So it made us think, as a charity, who do we target our resources that we develop towards, as well as patients, which health professionals.
Just 2 more bullets. One actually was very similar to what we have, which is encourage our patients to prepare, take notes, bring questions. I tell patients bring a family member, an advocate who can speak on your behalf if you forget something. A lot of our patients have the brain fog. They walk out going, I wish I had asked something. But if you have an advocate with you, perhaps remember some of those. And then the last is to recognize that there are some societal differences and things, and understand your patient's needs and concerns based on your specific experiences with family members and society and jobs and whatnot.
Excellent, thank you.
Thank you.
Yeah, you can keep this, and maybe if you want to take it further, a step further, maybe create some guidelines and disseminate some tips for the patient and the clinician. Yeah. And I think we're just right on time.
Perfect time.
Thank you so much. It was,
Thank you very much.
and-
It was a very nice topic, Susie,
Yes.
very good.
I think it's a very important
Yeah,
topic.
yeah,
Yeah.
because the communication between doctor and the patient is very important.
You want to take a picture or
Yeah.
shall we? You want to take this as well?